All right, so really what we'll be talking about are really the principles of the examination of the abdomen. With everything that has happened with respect to COVID, obviously you haven't had a lot of hands-on and come from junior clerkship, and so we're just going to be talking through what we expect you to do when you go to the bedside. During the 10 weeks, you need to examine as many patients as possible. And just starting out, it's important for you to get a feel for, what's the normal abdomen? What's the normal abdomen actually feel like in a pediatric patient before you move on to pathology? So just try to examine as many patients as possible. Of course, it's important to do this with your colleagues, but you can catch, like an intern or resident and say, hey, I'm feeling this. Is this, the liver edge, am I not quite sure, so what I'm feeling, just sort of speak to your senior colleagues just to ensure that you are definitely on the right track. Now, it's important for you to wash your hands or to sanitize before approaching the patient. In pediatrics, it's always or generally a child and a caregiver. So one, you want to ask permission from the caregiver as well as the child before you start doing any examination. You want to talk to the caregiver that's there for just a little to show the child that the caregiver is comfortable with you. So that's an important step so that there's not this heightened anxiety during the examination. Introduce yourself. Hi, my name is Anya Chuck. I am a final year medical student. Is it okay if I examine you today? If the child is there, or is it okay if I examine your child today? Once you've gotten permission, then you can explain what the abdominal examination involves and ensure that your patient is willing to do so. Once you've introduced yourself, get the patient's name. Part of your examination is establishing rapport. So once you've gotten the patient's name, then try to use the patient's name during the examination, right? So how old are you, Kyle? Which school do you go to? You try to sort of keep a rapport going. Obviously, this is all age dependent. So you have to see how to make the patient comfortable. You want to ensure that the patient is positioned properly during the examination and also adequately exposed. When we talk about adequate exposure though, please always consider the privacy of the patient. Adequate exposure for the abdomen, we say is from nipples to knees, but obviously in terms of privacy, considering we usually keep the genital area covered, and for girls, keep the breast area covered until the examination of that area is necessary. Go to the bedside being prepared. So have your tape measure to do the various measurements that are needed, and also your toys for the younger child to keep them engaged during the examination. As with any other system, the examination begins with observation. So you positioned your patient properly, right? Your observation starts from the foot of the bed. So you ensure that the patient is actually symmetrical, okay? So the patient isn't crooked or to one side, because remember that a lot of your observations will include looking for things that are actually symmetrical, okay? In interacting or talking with the patient, you will have an idea of what's the patient's mental status. Does the patient appear well? Is the patient actually ill? You will know what the sex of the patient is, okay? What childhood group does the child belong to? So is this a neonate, infant, is it a toddler, school-age child? Is this child a teenager? So when we talk about childhood group, that's what we mean. When, sorry, so what posture does the child actually adopt? We know that the body proportions change over time. You know, the younger the child, the head occupies a bigger area relative to the rest of the body. So the body proportions will change as the child gets older. Observe the degree of respiratory distress that may be present. So obviously, if you have a very enlarged abdomen, that can impact on the respiratory rate. And you may also see a degree of respiratory distress that may be present. I must caution, though, that because this is pediatrics, just to remember that the younger the child, the more flexible the order of the examination has to be. So you may make a lot of, okay, so you've gone ahead, done observation, you're approaching the child, they're getting nervous or anxious, you may have to do some auscultation, you may have to do things that are out of the sequence that you know. However, at the end of your examination, in terms of how you're going to report, remember there's a standard reporting style, and that has to stay consistent. So the observation, your palpation, your percussion, auscultation. But in terms of the actual examination of the child, you may have to be a little bit more flexible in terms of how that is actually done. As you inspect from the foot of the bed, you are going to comment on things that we mentioned before, get an idea as to what's happening with the nutritional status. Is there any obvious wasting that you can actually observe? What's happening with the patient's subcutaneous tissue? Are you seeing anything in terms of hair changes, whether it is alopecia, or if you're seeing things like flag sign, forest sign, things like that. Other areas of observation. So looking into the mouth, and you'd have moved from the foot of the bed by this time, but looking to see if there's any changes at the corners of the mouth to indicate any issues with nutrition. Also looking at the tongue to see if you're having a smooth, beefy red tongue, which may indicate obviously nutritional issues, any ulceration, dental caries. In patients who are syndromic, so if you're looking at the face or you're looking at other features, you may get a clue to see whether there's a clue to an underlying genetic condition. And I would say, as a medical student, if there's one syndrome that you have to know, definitely, and you will have to know more to know on, you'll come to this as well, but trisomy 21. So you can get a relative macroglossia, so you have a large tongue associated with something like Down syndrome, excuse me, which can come up in your examination as well. And there are other dysmorphic features, obviously, that you will have to look out for. Now, when we inspect, and the comment on the muscle bulk must be whether is what I'm seeing consistent with generalized wasting, or is this specific to a particular area? And therefore, you will have to look at all the different muscle groups. So I'm looking at the quadriceps, looking at the insertion of the deltoid. I am checking what's happening with the biceps, the infrascapular area, the temporal area, obviously, pelvic and shoulder girdles are different areas that you'd want to look, and not to forget the buttocks as well, which forms part of your overall comments. All right, with a patient who has liver issues, you may notice that there may be scratch marks. When you look at the patient's eyes, there may be evidence of jaundice. You may see some evidence of bleeding under the skin. And after puberty, you may see evidence of gynecomastia or evidence of hair loss. Now, the other things that one must comment on, so don't have something obvious and not comment on it. So if the patient is receiving, oxygen via nasal cannula, if the patient has an IV line in situ or special tubes such as an NG or gastrostomy tube, then comment on it, because it will form part of your clue in terms of what's happening with the patient. When you go to do the examination of the abdomen, another thing to remember is that This is examination that's done seated. So if there's not a chair, ask for a chair. You are going to be at the patient's level, seated. On some wards, you do have some beds that are high. So you can, if it's a high crib or a high bed, then if you are at the child's level, then you can remain standing. Otherwise, if it's a regular bed, then you're expected to be seated during the examination. Once you are, so I'll go on to what we look for in terms of when we actually inspect the abdomen, and then we'll talk a little bit about the hands. All right, so if I am inspecting the abdomen, so I'm looking from the foot of the bed and I'm inspecting the abdomen, then once the patient is positioned properly, I can make a comment as to whether the abdomen appears symmetrical or not. Is the umbilicus everted? Does it appear flat? Is it inverted? So especially, thinking about things like ascites, your umbilicus may be everted. What is the pattern of respiration? Is it thoracic, thoraco-abdominal, or abdominal? And that pattern changes as the child gets older. You need to observe for scars. Think through whether you think this scar is, surgical or non-surgical. And therefore, this may involve a quick review. A lot of our kids, we have a lot of patients with sickle cell disease, and therefore quite a few of them have had splenectomy. So what is it that, in terms of location, where would you expect that to be? If a child has had a laparotomy, or what are the different procedures and where are the relevant scars, surgical scars, located? All right, so are you seeing any striae? Are you seeing any spider nevi? Peristaltic waves? Are you seeing any distended veins on the abdomen? I'm sorry. So you'd have observed for that, and remember now that when we'd have done our general inspection, and then looking at the abdomen. When we go to touch the patient and you're seated now at the bedside, we generally start looking at the hands. All right, so what are we looking for in the hands? So we want to examine the hands for evidence of clubbing. And we know that clubbing may vary. So it may be gross clubbing, so you have this drumstick appearance. Or you may need to look for more subtle signs. So if you have that, loss of the angle of the nail bed, or if you have increased fluence, which may occur in a variety of conditions, such as, cystic fibrosis or liver disease, inflammatory bowel disease. So you want to do your general inspection for clubbing. You want to look for palmar erythema, which can happen with chronic liver disease, polycythemia, koilonychia, where you have the spooning of the nails that occurs with iron deficiency, leukonychia, flapping tremor. People, you can check for that because you can get it with liver failure. Generally, we don't see Dupuytren's contracture, as usually seen in adults, so you don't necessarily have to check for that. And then, so you'd have done the hands and checking for lymphadenopathy. When you check for lymphadenopathy under the examination of the abdomen, it's all groups that are expected to be inspected. So, epitrocular, axillary, cervical, you'd have done inguinal as well. So you need to do all the different groups. When we come on to the time of so now that you're at the beginning of the clerkship and you're just sort of getting a feel for the examination, don't worry too much about the timing in terms of getting through the examination in a time that would allow for you to get through everything in the OSCE, because right now At this stage, we just want you to be confident of your findings. So at every stage, you find something, whether it is, okay, so this lymph node, I'm feeling particular shape, its size is mobile, it's not, etc. I'm feeling, getting the liver span, the splenic size. So that's what you're doing in the first few, is getting confidence in terms of your signs and making sure that when you say something, that this is actually accurate. Later on in the clerkship, when we're coming closer to the end of the 10 weeks, then you can, start considering the timing, because for your OSCE, you have 7 minutes for this station, and you generally have 5 minutes to examine and 2 minutes to report or to interact with your examiner. So eventually, you probably will have to consider the timing, but for now, it is just making sure that you're comfortable and getting the actual signs correct. So why I mention that now is that during the examination, I usually suggest leaving the lymphadenopathy until a little later in the examination, because it does tend to take up a little bit more time, and you want to get through your examination of the actual abdomen during the exam. So in terms of your mucous membranes, obviously you're looking to see whether there's pink or there's evidence of pallor. All right. We mentioned before about the examination for icterus, and I did say about the mouth already in terms of what you're looking for. So ulceration, your beefy red tongue, your angular stomatitis, it looks like cracking at the edges of the lips. You can have candidiasis, which you can find, and I mentioned about dental caries as well. All right, so coming to the abdomen. So once you are seated, important for you to ask the patient, are you having any pain? Is there anywhere that's tender in the abdomen before you start the palpation? So if the patient indicates that there's a particular area that is actually tender, you will start your examination away from that area. You must practice, because you want the focus while you are feeling the patient's abdomen to be on the patient's face, because you want to know when you would have elicited any pain so that you would move away from that area. Once you are examining, you can divide the abdomen into either 4 quadrants, 9 sections, which will help you to report when any masses are felt. We usually start with light palpation, and you guys know that you would start in a circumferential pattern in terms of starting closer to the flanks, moving around the abdomen, and ending by the umbilical area. Okay. So when you're doing your, light palpation really means light. So we're trying to pick up if there's anything in terms of any superficial masses that may actually be present. When we do our deep palpation, we're actually checking to see whether we're feeling any masses or any organs. If you feel something, you need to describe it by sight, the size, what's happening with the surface. Is there any warmth, any mobility, any fluctuance, or any edges that are actually felt? All right. So for both light and deep palpation, remember that we are checking the abdomen in a very circumferential pattern, starting at the outermost area and then coming in and ending at the umbilicus. When we deal with organ-specific palpation, what's important to remember here is that you do each organ in sequence. So we're not going to palpate for the liver, then palpate for the spleen, and then come back to percuss the liver and percuss for the spleen. We do all the maneuvers for one organ, and then we move on to the next. Generally, we start with checking for the liver. The examination for both the liver and the spleen will start in the right iliac fossa. The palpation for the liver goes up towards the same costal margin or the right costal margin. The patient may be old enough for you to time with respiration, as when the patient breathes out, you move your hand up, or the younger patient, you're just going to do the timing with the patient's natural breathing. So you move your hand in a rhythmic fashion as the patient breathes in or out. You want to palpate to see if you can feel the lower border of the liver. So you palpate and then you percuss for the lower border of the liver. In terms of accuracy, palpating for the lower border should be more accurate, but I know that this may be problematic for some people, but you're expected to palpate and percuss for the lower border. And then you percuss for the upper border of the liver. You measure the total span, but you also want to measure the portion that's below the costal margin. So when you report, your liver span is turned.
I have a question. So in adult medicine, we can ask the patient to like put their finger there to like hold the bottom, like mark the lower margin.
Right. Yes.
How do you do that in Peads because they're kids?
So it is dependent on the patient's age. So we do that as well, even up to the little 5 or 4-year-old. We'll say, hey, just put your finger right there. But it depends on your patient. Suppose your patient isn't actually reliable, so we're not expecting you to mark the skin or anything. If the parent is there, you'll ask them to, so the parent or the caregiver is there, you'll ask them to put their finger there. And in an exam situation, you can certainly ask the examiner to do that as well. So it's the older child can assist, and as I say, a child who is 5 years or up can assist you, or if a caregiver is there, you can ask them to assist. That's okay? Who asked?
Yes, thank you.
So, okay, sure. So then remember, so I was just mentioning that in terms of measuring the liver span, please report the full liver span, but also report the portion that's below the costal margin. So we know that, children who may have, say, asthma or a respiratory condition that's going to push the liver down, you may find that the total span may be normal, but the portion below the costal margin may be increased, or if you have true hepatomegaly, then you may have overall that the liver span is increased and the portion below the costal margin is also increased. You're not expecting like more than 2 centimeters of the liver to really to be below the costal margin if this is a normal liver. The liver sizes for pediatrics are unorvially. So please have a look, familiarize yourself, because as with a lot of other things in pediatrics, things will vary according to the patient's age. So what is considered normal for a 3-month-old may not be normal for a 3-year-old child, and that goes for heart rate, respiratory, different sizes of different organs, all of that. So especially with respect to the liver, that's unorvially, so please have a look, you will find it. So that's about, so the liver, once you felt, so practice, see if you can practice feeling the liver edge. The majority of times it will be soft. Patients with liver disease, it might be a little bit harder. Patients with, sickle cell disease who may have hepatomegaly, you may find it a little bit firmer. You can try to see whether you feel the surface of the liver as as it goes across and the abdomen, checking to see whether there are any nodules, etc. So all of that is practice, but it's quite doable. So remember I mentioned about the spleen. So remember that the examination of the spleen also starts in the right iliac fossa, but now we're going diagonally across the abdomen. So the spleen on the left enlarges down towards the umbilicus, or enlarges down towards the right iliac fossa. So the patient is seated, you are seated, you start in the right iliac fossa and go obliquely across. Now, suppose you've done that maneuver and you're not feeling anything, your examination of the spleen is not over. You need to turn the patient on their side and start the maneuver again, meaning that you would start again in the iliac fossa and go up to see whether a really small spleen that would enlarge in that direction, you would now descend. So sometimes when you turn the patient on their side, a small spleen may come down and then you could feel the spleen at that time. I hope that's clear. So suppose we'll do this scenario. Suppose you actually do feel the spleen at that time. If you're going to turn, so you are seated. So you are seated. The patient is lying flat. Okay, you are seated on the patient's. Well, just so the patient is going to turn towards you. So the patient would turn towards their right side. So as long as the patient is turning towards you, so the patient is, I don't know if it's easy to describe. So the patient is just on their side altogether, and then you start the maneuver again. Now, in terms of the measurement of the spleen, it's important there are different ways in which you can measure the spleen, either vertically, so with respect to the midclavicular line, or you can see where the tip of the spleen is, the lowest point in the abdomen, and go from there and stretch your tape measure back up to where it intersects with the costal margin. So you can measure the spleen obliquely, or you can measure it with respect to the costal margin, and you're gonna get two different measures. Both of those are appropriate, and it just let us know how you've actually measured the spleen, because we'll take both of those. Now, if you've done your lateral maneuvers where you're trying to see whether the spleen has enlarged towards the umbilicus or across the abdomen, and you are not finding that, your maneuvers for the spleen still not over, because you need to see whether the spleen may have enlarged towards the left iliac fossa. So then you're going to start palpating now from that direction up to the costal margin. And if you're not finding that the spleen is enlarged there, then you can comfortably say that the patient has no splenomegaly. So the examination of the spleen does take a little bit longer because of the two directions in which it may enlarge. And it actually enlarges towards its own iliac fossa generally when there's some other organomegaly that's present. Now, if you have a mass that's coming from the left costal margin, then you can describe stuff to us to say whether you think that this is a spleen or not. And I think most people know what are the different features to say, we think that this is an enlarged spleen or not. And I'll mention them in a minute. So we mentioned before in terms of masses and organs, the size, the shape, surface, etc. So you go through all of that if you do find a mass, just to give you an idea of what it actually is. So we'd have done the liver check thoroughly for the spleen, and then we're going to we would ballot. For the kidneys, so you want to hold one hand posteriorly in the paravertebral space below the costal margin posteriorly, and then the hand at the top, basically on the top of the abdomen, and then you're going to move that hand that's at on the bottom and to push firmly up, usually 2 or 3 times, just to see whether you can actually trap the kidney in that space, or you feel a movement in that area. In a really thin child, you may feel, or you may ballot a kidney and it may not be pathological. In a patient, and we do have patients who have renal pathology, so you may find that one of them may have a large kidney. So I would, for the students that are at university, some of our renal patients are on ward 4, so I would just talk to the ward team to find out if there's any renal patient that's appropriate for you to examine. In terms of the features that we were mentioning before, so if you have a mass that's coming from the left costal margin, is this a spleen, not a spleen? So here are some features that you may not necessarily wait for someone to ask you. You could say, well, I noticed that it enlarges across the abdomen. It is not something that I could have gotten above, can't get between it and the costal margin. This mass has a notch. It was not ballotable. When I percussed over it, it was dull to percussion. All right. When I rolled the patient, the spleen descended, or the mass actually came down. All right, and we mentioned how to measure the different ways in which you could measure the spleen before. All right, so with respect to ascites then, there are two ways in which we check for it. So depending on the degree of ascites, so for smaller volumes, you can pick up by means of shifting dullness, where we demonstrate dullness in the flanks, or once the patient is rolled on one side and we have the theoretical shift of the fluid, then we go from dull in the flanks to resonant, and we would percuss towards the umbilicus and end the maneuver there. So just to run through it in a little bit more detail, so the patient's supine, you want to start your maneuver in the midline, so right at the umbilicus. And when you do your practical examination in terms of looking at the positioning of the hands would be important. So the hand is positioned with the fingers pointed towards the pelvis, okay? Be mindful as well that when you do your percussion, just to remember to lift your finger at the end of the percussion so that you don't dampen the sound. So that also requires some practice and paying attention to. But once you start the percussion at the umbilicus, then you want to do your percussion towards the flank that's closest to you. All right. So you make a note as to whether the percussion, the note changes or it does not change. So is it dull in the flanks or not? Then you want to also start again in the midline and percuss towards the flank that's furthest away from you. So at that point, make a note of the lateralmost point on the patient's flank whether it's dull or resonant, and turn the patient now towards you. You want to wait about half a minute, or a little bit less. And that's just to demonstrate that you're giving time for the fluid to shift. And then you're gonna start your percussion at that point and come towards the midline with the patient on their side, okay? Once you come towards the umbilicus, then you can turn the patient now back to lay flat on their back and then percuss over the umbilicus again, and the maneuver is finished. Now, that's generally in the absence of ascites. If you have a true shift and you do have fluid that's in the flanks, and you turn the patient and you've gone from dull to resonant in the flanks, you want to do your percussion and come across the abdomen until you come to the area that's actually dull again. Make a note of that point. Put the patient on their backs, making note of that point, and then you're gonna percuss again. And if we've gone from dull to resonant, we've demonstrated the shift at that point in time. So I know that sounds a little complicated, but and maybe some of you can picture it from your junior medicine rotation. So it takes a little bit of practice, but it's quite doable, and you just need to picture the shift of the fluid in the abdomen for it to really kind of make sense. So you want to go from that to the other way is to check for the fluid thrill. And again, you know, like some of the pediatric patients are going to be really small, so trying to put their hands in the middle of the abdomen, you may need to ask a caregiver, an examiner, someone who's there to assist you, to assist with the maneuver. All right. But once the hand is over the umbilicus to keep the abdomen steady, then one hand will be in the flank, and then you're going to gently flick from one side to see whether there's a wave that goes across the abdomen, and if the thrill is there, it's quite obvious. All right, so for grosser evidence of ascites, then the fluid thrill for smaller must be positive. In terms of checking for the bladder, so as you know, in pediatrics, especially if you're on the nursery, you're going to do a lot of suprapubic aspirates. So at the time, in terms of the neonatal period, certainly up to, so beyond infancy, certainly up to a year, the bladder is an abdominal organ, and then afterwards becomes pelvic. So it's easy for you to stick and do your SPAs for the babies on the nursery, right? So beyond that age, we don't expect to find an enlarged bladder, certainly in the abdomen, unless there's an issue such as obstructive uropathy, right? But when you're checking for the bladder, it starts with the percussion at the umbilicus down to the pelvis, checking to see whether there's any dullness. It does not start in the epigastrium, okay? I see anyone doing that, and we don't expect to see you doing that either, okay? So it starts generally from the umbilicus down. All right, so other important things in terms of the abdomen. Maria, which part was that? What did you want me to repeat about the bladder? Well, I was just saying that in terms of pediatrics, so I was saying that in terms of the bladder being an abdominal organ, especially when the child is born. So when we do our SPAs or suprapubic aspirates, you'll see that we'll stick a needle generally in that area. We expect to find the bladder once it's full, okay? We don't do it in an older child because the bladder then becomes a pelvic organ. So we wouldn't expect to, in an older child, certainly greater than 2 years of age, wouldn't expect to find the bladder being an abdominal organ unless there's some sort of obstruction or obstructive uropathy that's present. Okay. I think that's what I had said. And then the in terms of the percussion, that you start at the umbilicus down to the pelvis, and not to start in the epigastrium, right? I think that's the most of what I said about it. All right, auscultation, always important. So it's standard for you to check for your renal breweries. So whether there's any evidence of any organomegaly or any enlargement, you always have to check for your renal breweries. However, if you do have an organ that is enlarged, so whatever organomegaly you have, then, because you should check for your bruise over those areas as well. In terms of your bowel sounds, then you want to listen for your bowel sounds. You can, standardly, like in the left lower quadrant, you can do it in all quadrants if you wish, but certainly to pick up your bowel sounds. Now, one thing that I hadn't mentioned before, sometimes you do have, well, it's COVID time, I guess no one is coughing now. I don't know. We usually have, we talk about checking for the, over the hernial orifices, and usually ask the patient to turn their face and cough. I guess we probably should just check what's happening with that now. I guess palpating to see whether the defect is actually there, but I don't think anybody's being encouraged to cough these days. So it's just to make a note about the hernial orifices. With respect to the things like so genitalia, we might make a note of it, but no detailed inspection. In terms of the perineum, so inspecting the perineum to see, in terms of the anus, especially if we're thinking of dysmorphisms and dysmorphic syndrome, what's the position? There are other things with respect to the anus in terms of tone or wing patency, whether there are any tags that are actually seen, tears, evidence of any stool. The PR is not standard in terms of the pediatric examination, so we do not do that generally. If we think that there is some specific indication, we may do it at that time. But generally, we're not very invasive in terms of the examination. So we just spoke about the abdomen. Largely, before we check for sacral edema, we would want to go to the feet to check for any evidence of pedal edema, any digital clubbing of toes. When you check for pedal edema, it's just to remember that it's generally, you should be pressing for a minute over the lowest bony point that's there, usually by the medial malleolus, but in an exam situation, then probably not as long as that, but it's certainly longer than 1 second or pressing just, momentarily on that spot. So once you've checked for your pedal edema, then with the patient sitting up, you can check for sacral edema and also check for renal angle tenderness. And if it is that you did not actually get to finish your examination for lymphadenopathy with the patient sitting up, then you can do it at that point in time. So I know I've said probably a fair amount. When you actually do the examination, it goes by pretty fast. But it's just to remember the general principles of making sure that you've introduced yourself to the patient, make sure that you've maintained that rapport, caregiver and patient comfortable with you. You start with your inspection, foot of the bed, patient is positioned properly, and you can position the patient because if they're crooked or asymmetrical, you might come to the wrong conclusions. Think general, so what's happening with their, nutrition, what's happening with the breathing, are you seeing any hair changes, etc., observing any jaundice, scratch marks, etc. What's happening with the abdomen, what is it that you're actually seeing? Not to forget the whole syndromes we mentioned about trisomy, but things like prune belly as well might be even more relevant to the abdominal, examination. Start with the hands, go to the face, do the examination of the abdomen as we have outlined. All right, and just practice, practice, practice. That's going to be the most important thing. All right, any questions about what I've said or? A per-rectal examination, the digital rectal examination. Sure. And just remember what I said about the younger patient, that certain things in terms of even, like a very young child being expected to lie still for the examination doesn't happen. Sometimes for, the 1-year-old, the 6-monther, you might just have to leave the patient on the caregiver's lap and do the examination from there. All right, I'm available for any questions if anything comes up. All right, no problem. Take care.
Thank you.